Hello, my name's Peter Todd. I am a renal and internal medicine registrar working in the Ulster Hospital in Northern Ireland. And I'd like to thank the Royal College of Physicians of Edinburgh for sponsoring me being here. The case that I'm going to present is going to ask you the question, kidney disease, is it worth the wait? So we were referred a 60-year-old gentleman to the renal clinic by the diabetes team. And the concern with this gentleman, he had a background of type 2 diabetes and obesity, and the main concern was a recent decline in his renal function over the past year, quite significantly from a normal renal function to an EGFR of 22 by the time that we saw him. On our first assessment, we noted a few things. Firstly, his urine ACR was normal, so he had no proteinuria. He also had a moderate hypercalcemia, and he was asymptomatic. And in fact, more than being asymptomatic, he was on a health kick, and he was feeling really, really great. On the encouragement of his diabetes team, he'd been eating well, he'd been exercising, and he had lost weight over the past year. He'd lost 27 kilograms, and he was very proud of himself with that. And along with that, his diabetes, his glycemic control had improved significantly with an HbA1c of 42. But the renal impairment was clearly concerning, so I performed a renal biopsy. And the main thing that we noted on the renal biopsy were these silvery grey deposits which are in his convoluted tubules, which are the quite atrophic convoluted tubules. Our pathologist was able to do quite a cool thing by shining polarized light on the samples, which showed these deposits shimmering with birefringence of the polarized light, which sort of splits it across the spectrum of light, which is a unique characteristic of calcium oxalate, which confirmed these as calcium oxalate deposits, and therefore the underlying diagnosis here was oxalate nephropathy. So that brought us back to the question of why was this happening in this gentleman? So I contacted the patient, and I dug a little bit more into his over-the-counter medication history. And at this point, he admitted that he had been buying Orlistat online. It's a non-prescription medication that's available from reputable websites, and that had been assisting his weight loss. Orlistat is an intraluminal lipase inhibitor. I'll talk about it a little bit more later on. He also had been buying multiple vitamin supplements just at a high street health shop. And when I asked him to bring in his vitamin supplements so I could see them, he arrived with a kit bag full of these vitamin supplements. It was hard to fit them onto the desk in the consultation room for me to be able to see them. And when I looked through the ingredients of these, in total, he was taking a huge amount of vitamin C. He was taking more than 60 times the recommended amount of vitamin C. He was also taking over 30 times the recommended amount of vitamin D every day just in these vitamin supplements, which he was getting over the counter, and his serum vitamin D level was very high. Now, how is all this relevant to his oxalate nephropathy? Normally, there's oxalate in your diet, and the vast majority of your oxalate gets bound to calcium within your gut. When it binds to calcium, it doesn't get absorbed and it gets excreted fecally, with only a small amount remaining unbound, which is absorbed and is excreted in the urine. When someone's taking Orlistat, there's reduced fat absorption. It's how it works. And what happens then is the calcium in your gut preferentially binds to the fats that are there, and it means that there's no calcium left to bind to the oxalate, meaning that you lose that ability to excrete oxalate fecally, so all of it gets absorbed and excreted in the urine. So from that step, with his oxalate leading to increased with his Orlistat leading to oxalate excretion in the urine, how do the other factors come into play? You'll never guess, but vitamin C in the intracellular compartment is metabolized to oxalate in a large part, so that increased the oxalate load that needed to be excreted in the urine. And his vitamin D was causing vitamin D toxicity, which was leading to that hypercalcemia that we noticed at the start, which then led to an increased urine calcium concentration. And that high oxalate concentration and high calcium concentration meeting each other in the urine caused immediate crystallization into calcium oxalate crystals as soon as they met in his proximal tubules, which is what we could see on the biopsy. So this gentleman's renal function the best treatment that you can do for people is to ask them to stop taking things, and all we did was ask him to stop taking his non-prescription medications that he was buying. His EGFR reached a nadir of 8, and at that stage he was feeling unwell. He was developing uremic symptoms, so we very nearly started him on dialysis, but thankfully his renal function improved soon after that, and it ultimately has leveled out with an EGFR of about 30 to 35, so he's been left with fairly significant CKD. So our learning points from this: first of all, awareness of over-the-counter medications is vital. It's something that I probably should have delved into the first time that he presented and really only went back on after the biopsy. But they're not just over-the-counter anymore. The use of the internet for accessing medications is growing. There's also clearly a propensity for these to cause severe harm. In this case, probably the orlistat and the vitamin C interaction was the main driver. And patients can be reluctant to give you information about over-the-counter medication, maybe because they feel like they may get some sort of negative thoughts from healthcare professionals. Also, renal impairment in diabetes is not always diabetic nephropathy, and particularly in this case, when there was the absence of proteinuria, was a clue that we needed to look for other causes. And finally, these days there are safer alternatives for managing obesity and type 2 diabetes. GLP-1 agonists have been demonstrated to even have cardiovascular and renal protective benefits. So I'll bring you back to the original question in this case, which is kidney disease. Was it worth the wait? I'll leave that for you to decide. Thank you.
Thank you. Thank you very much. Roman, over to you. Thank you.
Well, it's okay. So, all right, we have more questions than.
Okay, I'm Rampakush, nephrologist. So thank you for a nice case. So I missed the urine microscopy finding. Usually we see the oxalate in the urine microscopy.
Yeah, we didn't do urine microscopy. It's a controversial topic amongst nephrologists. But there's in our centre we don't have the urine microscopy capacity.
So what was your working diagnosis that led you to decide in the urine and the kidney biopsy? Because the pathologist it is easy to miss the oxalate in the biopsy.
Yeah. I mean, certainly, to be honest, we weren't expecting that. My working diagnosis was sarcoidosis, with the combination of minimal proteinuria, the hypercalcemia, and recent weight loss. He also, I hadn't mentioned it in the case, but he had in his adolescence, he'd had a biopsy of his nose, which had shown some localized nasal sarcoidosis. So I'd presumed that it was likely to be sarcoidosis. Thankfully, we had the facility that we were able to do the biopsy relatively quickly, so that we were able to confirm the diagnosis that it wasn't sarcoidosis before we treated.
Thank you. That was an excellent case, and I think a really important teaching point about asking about everything that's not prescribed. In fact, in our EMR, I put in a smart phrase to alert the residents and the house staff to ask about anything that's not prescribed, because we're picking up a lot of junk that's causing a lot of harm. So not only is it causing therapeutic harm, but diagnostic harm. Things like biotin can cause false abnormalities in ferritin levels, carcinoembryonic and antigen levels. So it's really, really important. So really well done in terms of highlighting that point. The question that I have for you, a couple of questions, is the vitamin D level wasn't that high, if I remember the units.
No, it was 97. It wasn't.
It wasn't that high.
Yeah.
Like, it wasn't toxic. Was the parathyroid hormone level measured, number one? And number two, was a 24-hour urine oxalate level done? I just wanted to know how high the urinary oxalate was.
The parathyroid hormone was done, and it was suppressed. It was low. We tried to get a 24-hour urine collection for the oxalate levels, but the patient himself wasn't able to engage with it. He sort of failed on 2 occasions, and ultimately we didn't pursue it further because we had the diagnosis and the biopsy. But yeah, yes, it's. I think it also it teaches me a little about the role of our communication in sort of giving health advice. I think he had presumed, being told that vitamins and weight loss were good, and then therefore more vitamins must be even better, and he couldn't really understand that all these things that were supposed to be good were causing causing problems, and you know, he was a little bit sort of almost upset by by that. So it's something that we can learn from our own communication that way, I think.
They're only good until you get admitted to hospital, right?
Yeah.
And the last thing is orlistat is, in the clinical trials for Xenical or orlistat, it's not a big common finding so it's really interesting that this happened.
Yeah, there's certainly lots of published cases of orlistat causing oxalate nephropathy, I think, and there are cases of vitamin C over ingestion causing it separately as well. So I think that the two things probably just both contributed in this case.
Let me ask a question, because we went on fairly superficially. Your hospital does not perform urine analysis?
Oh no, we do urinalysis, but we don't do urine microscopy for crystals.
So something which in the old textbooks and movies we've seen, the first thing the intern was doing, taking a sample and looking under the microscope. It doesn't exist anymore.
I'd say it depends on the unit, and I think it depends on.
So we go straight to biopsy.
All right, Roman, we have to finish.
Cases.
Thank you so much.
Thank you.
Thank you so much. So now.